No, sorry. All right, the last three we're going to go through. Okay. Why don't physicians in the United States, who knows about EKG-based tip location? Okay. Why don't physicians in the U.S. use it? It's clinically better because you can tell during the procedure whether you've gone the right way or wrong, and it's cheaper than a chest x-ray. When I find those two things, if you're not doing it, one of us is irrational. If you're not doing something that's better and cheaper, one of us is irrational. So here's the deal on this. Just gonna skip through. All right, like my buddy from before, so I needed 26 centimeters to get down to the cavo-atrial junction from the right side. Suppose I wanted to put a 26 centimeter catheter in this hospital. What would you give me? All right. Here's how this works. The pacemaker of the heart is the SA node, as you guys know better than I do, right? The SA node is thought to be at the junction of the superior vena cava and the right atrium. I've been in the heart surgery with the cardiac fellow going, oh yeah, the SA node's right. I don't think anybody's ever seen the SA node with their eyes. You know what I mean? I haven't. You know what I mean? But this is where the SA node is. In this pictogram, it's right here where the cava and the right atrium are coming together. So in the normal surface EKG, you have the sensor down here, and the generator is the heart in the center of the chest, right? And this is what an EKG looks like, schematically, and this is what it looks like in a real patient. Small P wave atrial musculature, large QRS ventricular musculature, and this is what it looks like. But suppose we put the sensor, instead of it being on the thigh, suppose we put the sensor at the cavo-atrial junction. What do you think would happen to the P wave? It's not 25 centimeters away now. What do you think would happen to the P wave? It becomes a monster. Because our sensor's right there where it's being produced. I'm going to show you a video on this. Concentrate on the P wave progression. Concentrate on what happens to the P wave.
We're going to talk about EKG guidance of the catheter. So I estimate from the left axillary position that he's going to be about 28 centimeters down to the cavo-atrial junction. We're going to remove the inner cannula and the wire. Now we're going to insert our catheter with the guide wire.
There's a wire coming out the end a little bit.
The wire that's inside the catheter. We're at about 21 centimeters. We see a prominent P wave. I'm into 23 centimeters. And you can see the P wave enlarging. So we know that we're heading down toward the SA node. 26 centimeters, we see an even larger P. So we go to 27. At 27.
So we see a negative deflection first before the positive. It tells us we might have gone past the SA node.
At 27, we got a very large negative spike. At 28, the spike becomes even larger, the negative spike. Now we're at 29. Now we see a change.
See all these changes. Now we're past the SA node, so it's the altitude is going down, the amplitude.
27, which coincided with our measurement.
So you've kept the lead to the guide wire.
27 centimeters.
Yeah, there's different ways to do it, but yes, the RA,
in this position.
this lead to the wire, yes. So here's the chest X-ray, confirming that it's another way of looking at it. All right, I got probably about another 8 to 10 minutes. If you guys have to go, you have to go. All right, chest X-ray versus EKG. It's like it's clinically better because you can tell if you're in the right spot or the wrong spot, and you can make your move to fix it while you're sterile. It's really dramatically clinically better. It's cheaper than an X-ray. There's no radiation. The nurses in your institution are using it. Like, I don't get it. It's been going on in Europe for 25 years. Why aren't we doing it? I honestly don't get it. I've been doing this for 8 years. Hold on, 7 years. I've been doing this for 7 years, and we don't get a chest X-ray. We just look for the sliding lung, for the pneumothorax thing. But like, I don't get it. And I like to hear a reason why the MDs. Forget it. Yeah. All right. So I'm going to go into cost effectiveness. Man, it's great. So I heard this term a million times, I didn't really understand it. But if you do cost effectiveness, so this is the effect difference, and this is the cost difference. And it gives you 4 quadrants, right? It gives you a left upper quadrant. So in the left upper quadrant, somebody will come to you and say, this doesn't work as well, but you have to pay a little more for it. Don't get that. If that's their pitch, don't get that one, okay? This one down here, it's not as good, but you save money. Usually we don't go in that direction either. This quadrant, something's better, either a little better or a lot better, but you got to pay more for it, either a little or a lot. This is the one where supply chain helps you out to decide, is it cost effective up there? The bottom quadrant is something that's more effective and it costs less. If anybody ever comes to me, and it's rare, comes to me in here, I don't stop till I get it because it's irrational not to do it. So if somebody can demonstrate that this thing's better and you save money and you don't get it, then I just have to leave. Because, do what you want. Keep going. Hey, you guys, you got it all together, And I think the EKG thing is in that right lower quadrant. It's better, and there's no radiation, and you save resources. What do I have to, what more can I say about it, I don't know, they got this. All right.